Good afternoon. I'm Catherine Santoro, Director of Policy and Development at the National Institute for Healthcare Management, or NIHCM Foundation. NIHCM is a nonprofit, nonpartisan research and education foundation dedicated to improving the effectiveness, efficiency, and quality of the U.S. healthcare system. We're pleased to have partnered with the Association of State and Territorial Health Officials, or ASTO, on our webinar this afternoon. It's now my pleasure to introduce and welcome Dr. Hudak from the University of Florida, who will be moderating our event today. Dr. Hudak is an expert neonatologist and an accomplished researcher in clinical neonatology and community outreach, and we're so pleased to have him with us today to moderate and also to present later on our webinar. Dr. Hudak?
Thank you, Catherine. Hi, everyone. I'm happy to welcome you today on behalf of NIHCM and ASTO to this webinar presentation entitled The Neonatal Abstinence Syndrome, Strategies for States and Health Plans. So all of us, I guess, on this call recognize that a recent steady increase in the use and the misuse of prescription opioids and a resurgence in illicit heroin abuse has fueled what can only be described as an epidemic of neonatal abstinence syndrome, or NAS, in this country. Infants who develop NAS may demonstrate intense signs of withdrawal that can be painful to watch. These babies spend on average 2 to 3 weeks in the hospital, and they can stay as long as 2 to 3 months undergoing treatment. NIHCM and ASTO have brought together a panel of speakers today who have expertise in a number of areas to discuss strategies for preventing and treating NAS. I'd like to call your attention to the fact that short bios for everyone today, copies of their slides, and a resource list of additional materials can be found on NIHCM's website, www.nihcm.org, on the Maternal, Child, and Adolescent Health Corner under the Conferences and Webinar tab. Also, an archive of today's webinar, including slides and audio, will be available on the website within a week. Those of you who are joining us today by phone will have an opportunity at the end to ask questions. Also, please feel free to submit any questions during the presentation, and we'll do our very best to try to answer those, if not by phone today, perhaps by email. So at this time, I'd like to introduce Cecilia, or Cece, Spitnoff, who is a Senior Science Policy Advisor in the White House Office of National Drug Control. She will also share some federal efforts and recommendations for states and health plans to implement going forward. Cece.
Hi. First of all, I'd like to thank Leslie at ASTO and Claire and Catherine at the NIHCM Foundation for inviting ONDCP to participate in this webinar today. I'm delighted to talk with you about the National Drug Control Strategy and the work that we've been doing here on the prescription drug crisis, opioids, maternal addiction, and drug-exposed infants. And I also want to give special thanks to Stephen Patrick, who is a physician at Vanderbilt who has been working with us on this effort. He is one of the people who identified that there was growing concern with this issue. And I'll be talking about his research in a few minutes. And I also want to say that we have a team of people here in the room, including Dr. Kim Leary and Megan Lynch, who are helping to work on this policy issue with us. And I also want to thank all of the participants who are on the line. We're up to over 400 people now. And my mother is a former retired nurse case manager who worked for a managed care organization for a very long time. So I really appreciate the challenges that people have who work in this area, and I'm very glad that there is so much interest. So ONDCP initially became involved with this effort after Florida and also Dr. Patrick published related to this work. And I was in charge of organizing a national leadership meeting that ONDCP held in the summer of 2012. And here are just some pictures from this meeting. And a lot of the credit for getting this work going goes to our former director, Mr. Gil Kurlikowski. He was very excited about working on this, this issue after he participated in the initial Florida task force that Attorney General Pam Bondi had been in charge of. And in Florida, they were noticing that there was sort of a growing cohort of drug-exposed infants, and hospitals were interested in obtaining more information and better information about dealing with this. So the meeting that we held involved federal partners, staffers from congressional offices, and many of our National Association partners, including Leslie Erdlach from ASHO, who's on the call today. And it was a really good chance for researchers, clinicians, advocates, and policymakers to meet and raise awareness and consider potential solutions for dealing with this problem. And if anybody decides that they want to look at the slides further, that link on the top actually will connect to the White House archive for, I think it's actually the ONDCP YouTube channel. Actually, I think it's the White House YouTube channel that it's archived on. It's an 8-hour-long meeting. It's long, but there's a lot of good content on there. So I recommend that people who want to dive more deeply into this take a look at that. So as I mentioned, Dr. Patrick published a paper in May of 2012 that got quite a bit of attention, and it was published in the Journal of the American Medical Association, and was one of the big reasons why we decided to hold this paper. It was the first, or hold this meeting. It was the first time that we had really noticed on a national level publication documenting that there had been a rise in the rate of diagnosis of neonatal abstinence syndrome births. So from 2000 to 2009, they discovered that there was a nearly threefold increase to 3.4 per 1,000 hospital births. And so this is national data. We've since had an opportunity to work with some other states and to map data related to these diagnoses more on the local level. And in some states, there are much higher rates than this in certain pockets of the state. So that's one of the things that I think is really important to be aware of, is that there can be very spotty, patchy coverage in terms of where hospitals are seeing this and then where hospitals aren't seeing this. So it may not be happening uniformly across a given state. One of the other things that Dr. Patrick noticed, this slide shows the mean length of stay and also the hospital charges and what on average they were. And just to point to 2009, the mean length of stay was a little over 2 weeks for these infants. And the cost of treating this condition is rather expensive. Usually they're treated, if they require medication, they're treated in the NICU in a lot of places. So one of the things that researchers are interested in looking at is whether there are ways to change this and address this cost. This next slide shows the differences in terms of cost to various payers. And I believe it was about over 75%, about 80% of the babies were actually Medicaid babies. And you can see here that the charge is highest in that group. But also that the total charges grew from $190 million to $720 million. And that's a significant change. So obviously that's something that we're concerned about. So for those of you who don't know very much about ONDCP, I confess I only started working here 3 years ago, and I didn't know very much about it a while back either. So our office is a very small office within the Executive Office of the President. And we are charged with coordinating efforts related to drug control across the entire federal government. One of the things that we do is produce a report for Congress every year, and that is the National Drug Control Strategy. And we just released the 2014 National Drug Control Strategy last week. So I would encourage you to go online and take a look at that. But one thing that we also are able to do is to release special policy documents that concentrate on certain areas that we think need more attention. And in the 2010 strategy was the first strategy for this administration. And it addressed treatment, and it also addressed prevention and recovery. But at that time, we were noticing that there was a large increase in the rate of overdose and also the rate of prescription drug misuse that was appearing in the literature. And so we thought that it would be important to develop a prescription drug abuse prevention plan. So we have a special prescription drug abuse prevention plan that was released in 2011, and that is also available on our website. And it was focused on, what additional could we be doing in order to address prescription drug abuse and specifically try to prevent new initiation, new cases. So we had 4 main focus areas for this. And one of the focus areas was education, both in terms of educating the public and in terms of educating practitioners. And we know that prescribers do not, especially in their medical school training and their undergraduate level training, they do not get very much education on pain management or how to identify and treat substance use disorders or people with these problems. So education was one of our pillars. We also had an emphasis on monitoring and using prescription drug monitoring programs to address this problem, to help with people who might be doctor shopping or to help identify people who may be developing a prescription drug problem. We also, the third pillar has to do with proper medication disposal and also proper medication disposal and also storage. We know that a large number of the medications that people admit to misusing, they are actually receiving from friends and family. And there's a lot of unused, unwanted medication sitting around in people's medicine cabinets, and that poses a diversion risk. And that's how people sometimes begin to engage in this problem. And then the final topic was enforcement and strengthening existing laws. And there was a recent CDC report that just came out that looked at how laws have been changed in Florida and what the impact of that has been on their prescription drug issue. So I would encourage people to take a look at that as well. Since we released the plan, not only have we learned more about neonatal abstinence syndrome and the increasing rates of that, but we've also seen more data concerning overdose and heroin misuse. It appears that some people, many people who become heroin users have used prescription opioids prior to becoming heroin users, although the number of people who actually go on to try heroin from prescription drugs is very low. And we've also seen, especially in young people ages 18 to 25, increases in hepatitis C that are concerning. So in the 2014 strategy, we update the prescription drug abuse prevention plan and talk more about these different issues, including NAS. So I would encourage you to take a look at this if you have an opportunity. And the reason that I'm spending so much time talking about the plan is that we firmly believe that states that begin to engage in the activities that are advocated in the plan will start to see decreases in the overall rates of prescription drug misuse. And we are very hopeful that this will have an impact on NAS rates. So that's the first thing that I want to go into here. And also I want to say that one thing that ASHTO has done that has been very helpful, and I'm sure you'll hear more from Leslie about this, is they have taken on the issue of prescription drug abuse for reducing overdose as their presidential initiative for the past year, and they're interested in reducing that by 15% by 2015. And I think that the activities that they have in their plan also will have an impact potentially on NAS rates. So the takeaway from this is that there's some good things that are going on. Now, this next slide talks about categories of maternal drug use that can contribute to NAS. And the one thing to keep in mind is that many people who have a child who is exposed to prescription drugs may be having that because they have a legitimate medical condition that is being treated with opioids. Or also, because it's not only opioids that can contribute to this problem, maybe psychiatric disorder that they're being treated with sedatives for. So chronic pain is an extremely important thing that we need to maintain access to treatment for, as are psychiatric disorders. And two of the treatments for opioid use disorders, methadone and Suboxone, or a medication that contains buprenorphine, Subutex, those are both very useful for treating serious opioid use disorders. And these drugs can cause NAS. So it's probably unrealistic to think that we would be able to completely stop NAS from happening, because there will be some pregnancies in some of these individuals, either unintended or intended. And sometimes this can happen, obviously, from misuse of these medicines or for misuse of somebody else's prescribed medicines. And that's one of the areas that I think it's really important to cut down on. And then, of course, certain Schedule I drugs can also cause NAS, like heroin. And so those are some important things to keep in mind. We're interested in reducing NAS incidence where possible, while preserving access to needed medical treatment. And there have been a number of federal activities that have happened in the past couple of years. An example is that the FDA, the Food and Drug Administration, they actually had a box warning that they placed on extended-release, long-acting opioids, so prescribers would be aware that they can contribute to neonatal abstinence syndrome. And that's an example of a federal action that could take place, a regulatory action that could take place that could have an impact on this problem. Another thing that we think would be very helpful, and that people may have ideas about facilitating, is efforts to identify women early who might be at risk of having a baby with this problem, and discussing the role of opioids. It appears I am out of time. I'm going to speed it up. Discussing the role of opioids in this issue. In terms of some of the activities that ONDCP, actually, we'll skip this one slide and go to the next slide. ONDCP, along with the Prescription Drug Abuse Prevention Plan, had a number of action items that were assigned to various federal agencies and federal partners. And so these are some examples just from the Prescription Drug Abuse Plan that I think would have some bearing potentially on either health plans for reducing prescription drug misuse, or maybe potentially also on neonatal abstinence syndrome. So in the first example, exploring the feasibility of providing reimbursement to prescribers who check the prescription drug monitoring programs before writing controlled substance prescriptions for patients covered under insurance plans. That's an example of something that could potentially help with this problem. We actually had a meeting in 2011 that looked at evaluating existing programs that require doctor shoppers and people abusing prescription drugs to use only one doctor and one pharmacy. We're also interested in working with CMS, the Center for Medicare and Medicaid Services, and HHS to look at the possibility of using state PDMPs for reducing Medicare and Medicaid fraud. And Then we have two more items. One is using developing tools to facilitate appropriate opioid prescribing, including developing patient and provider agreements and guidelines. So decision support tools that would facilitate appropriate prescribing. And then the last one has to do with using screening, brief intervention, and referral to treatment programs to help healthcare providers identify and prevent prescription drug problems in primary care, and working on incorporating the use of health information technologies such as electronic health records into these screening, brief intervention, and referral to treatment programs. And I just want to say we realize that screening, brief intervention, and referral to treatment may not necessarily be all that you need to do with somebody who has a brewing opioid use disorder problem. But we think that this can be really helpful. It's very important to start to identify people who are actively using and to make pathways and linkages to treatment for them. Only about 30% of opioid users in a given year go into treatment. And it's really critical for these women to start making it there. Now, this next slide kind of breaks up what ONDCP can do and what we have done in the past year related to this issue. So as I said before, we coordinate the federal activity, and there's technical assistance that we can give. We can hold meetings and go to meetings, and we attended we had a vision session at a summit this year on NAS to try to get information from the public about what might be good to address this problem. We also attended a State of Tennessee and Appalachian Regional Commission Experts Health meeting on this, and we have an opportunity. Our director has a little bit of a bully pulpit to engage with the press, and so he went on a visit to Vanderbilt to the NICU and was able to bring attention to the issue there. We also hold convenings, and we recently held one on heroin that the Attorney General and the Governor of Vermont attended. So there's a variety of activities, and the folks here in this room are working very hard and diligently on pulling together an internet resource center where we can have all of the different resources that we've located on this topic together. Finally, I would like to just say that there's a lot of challenges with this issue, but there's a lot of opportunities. And one thing that we identified through our meeting is that it's really important to try to address these consequences without contributing to stigma and making problems worse for infants and families. There's a lot of research gaps and more research that's needed on identifying the best way to address these problems. And obviously, as I mentioned before, with 4 out of 5 newborns with NAS being paid for by Medicaid, there's implications for state budgets, but there's also opportunities to work with states on this. And clearly, we want to do more in terms of educating prescribers, pharmacists, and patients about the appropriate use of opioids, building treatment capacity, and looking at whether there's incentives that we can use in Medicaid or through other insurers to try to address this problem. So I look forward to hearing about the rest of the activities that other presenters are engaged in. And this is just a list of various links. I think that they're all active, and I would encourage you to go ahead and take a look at these as well if you get a copy of the slides. Thank you.
And our next speaker I'm very pleased to introduce is Leslie Erdelak, who is a Senior Analyst for Injury Prevention and Behavioral Health at the, I'll just say ASTO, which is a nonprofit organization that represents state public health agencies in the United States, as well as in our territories and freely associated states. So Leslie's presentation will draw on examples from health departments and others and outline a few key public health considerations. So Leslie, you're on.
Thank you, and good afternoon. I'm really pleased to have the opportunity to speak with you today on behalf of ASTO about some exciting projects and collaborations that are happening both at the state level and in communities and health systems nationwide. So what I'm hoping to accomplish during my time with you today is summarized on this slide. And because NAS is a multi-generational problem and because it spans so many phases in women and children's lives, there are many, many state agencies, healthcare providers, and community-based services potentially involved. So at the state level, state health departments are really well positioned to support public health approaches that take into account the really complex issues that are associated with pregnancy and opioid exposure. But at the same time, there are a lot of unanswered questions about how we can effectively identify and treat infants with NAS. But I'm going to talk about some of the current activities and quality improvement efforts that are working on resolving some of these gaps. And then finally, I'll outline some recommendations from a report that ASTO developed that highlights some state examples and proposes opportunities to work with and across other agencies and sectors. So I have a couple of introductory slides here, and I think that we all know that there's been considerable attention surrounding unintentional drug overdose deaths. But a comprehensive approach, and one that spans this continuum and is inclusive of all of these different principles and appropriate strategies and interventions spanning each of these four categories, is really the only viable way, I think, moving forward in terms of many things, but sustainability. And I think it recognizes, as Cece pointed out, that there's a need to balance regulating controlled substances with ensuring that people have access to medicines that adequately treat their pain. So every year, ASTO launches a year-long initiative that focuses on a national health issue. And last September, in 2013, we introduced the 15 by 15 challenge to urge health officials, together with their leadership teams and the administrators of other agencies across the state, to commit to working on identifying and strengthening different policies and programs in order to drive down the rates of misuse and overdose deaths. So I'm pleased to share with you today that we have 38 states and 1 U.S. territory that have committed to this effort so far. The commitments that we've received in terms of pledges from the state public health officers span all 4 of these categories that you see there on the right in the blue boxes. And again, we have commitments ranging from expanding overdose prevention and provider education to really optimizing the efficiency, the real-time capabilities, the utilization of state prescription drug monitoring programs, or PDMPs, working with drug courts and partners in the criminal justice system, and ensuring access to treatment, and importantly, I think, ongoing recovery supports. So as we're characterizing different approaches to NAS, the principles that were included in that comprehensive framework, I think you'll find, are a really appropriate and good fit here too. So one of the things that this slide suggests is that when we're talking about preventing substance abuse, when we're talking about preventing the vertical transmission of opioid dependence and NAS, we have to be thinking about social determinants of health and about those risk and protective factors that are associated. So while it might not always be the case, many times these women and their families are exposed to a lot of toxic stressors over prolonged periods of time, and so resilience becomes a really important factor. And it's critical to link them with services that can support them in both parenting and in maintaining good health. So again, in this sense, a comprehensive approach provides that type of foundation and points out the types of resources that you need across this continuum of care to link individuals and families with the services that they need, like substance abuse treatment, mental health services, early intervention services, family planning, and peer-based recovery support. And I think because there are so many potential handoffs between different agencies and providers, that's another reason why you need to have this collaborative infrastructure so that these women aren't getting lost during these interactions and during points of transfer between services. So next I'm going to talk about prevention and intervention opportunities, and this is going to be a relatively quick overview. The supporting rationale and data for each recommendation that I'll go over is contained in this report that you see on your screen. We published this earlier this year, and you can download it from our website using the link that I've provided there. And I do want to take time to acknowledge Dr. Meena Ramakrishnan for her excellent contributions to this project as both the writer and primary researcher of what we feel is a really valuable resource. So the intent with this publication was to identify how state health agencies could better support mothers and infants that were affected by opioid dependency. In doing so, we identified a number of promising state examples that are in the middle of generating important data about the problem and about the response to help move systems toward better standards of care and better measures to evaluate outcomes related to NAS. But there are a lot of unanswered questions about how to operationalize and approach this type of work, specifically in the area of data collection and tracking, treatment approaches, and negotiating the negative and I think sometimes punitive ways that women with opioid dependence are often treated. So in terms of primary prevention, public health, state health departments, and health plans in particular can support each of these items in some capacity. And there are a couple things I'd like to emphasize. The first thing is safe and appropriate prescribing of controlled substances is a priority for a lot of state medical boards. Many state health departments have taken steps to ensure that PDMPs and other clinical decision-making tools are available at the point of care to help try to prevent cases where drugs are being diverted, and in cases of overprescribing, just to really tamp down on the excessive supply of opioids. The second thing I would point out is that providers who are prescribing medication for pain management, for psychiatric or for neurologic conditions, or who are working with opioid replacement therapy, they're in a really good position to talk with their patients about family planning to prevent, again, as Cece mentioned, an unplanned pregnancy in women who are on therapeutic regimens or who might be at risk for misusing these types of drugs. Women who are in treatment may have unmet or otherwise complex reproductive health issues, particularly around contraception. So this is an opportunity to initiate those types of conversations. Tobacco cessation, and that's not on the slide, but tobacco cessation is also really important because smoking can contribute to the severity of NAS, and so health plans and other programs like state quit lines can help provide these important cessation benefits. In terms of identifying opioid dependence during pregnancy, ACOG, or the American College of Obstetricians and Gynecologists, they basically say that screening for substance abuse is a part of complete obstetric care. And so we can be helping advance prenatal screenings as part of the expected standard of care by promoting it, by normalizing it as part of the dialogue in healthcare settings. Some states have also added expert coverage to their Medicaid programs, but one issue that providers and obstetricians have identified is their concern that if they screen positive for substance abuse, sometimes there isn't any place to refer to, which is a significant challenge and I think speaks to the need to greatly improve treatment capacity. I won't speak in too much detail about managing opioid dependence in pregnancy because I think my co-presenters probably have more extensive clinical background on the subject, but one of the goals of medication-assisted treatment during pregnancy that sometimes gets overlooked is empowering, how it can empower the mother to really take charge of her recovery. Pregnancy is an important period for offering these types of services, and here care coordination is essential. So one of the recommendations that we present in the report is for states to have data collection systems to better track the number of pregnant women that are referred for treatment services, and then what are those treatment outcomes for women who are identified through prenatal screening? So there are a number of different approaches and a few different scoring tools that are used to screen for NAS, and there's sometimes a lot of variability in how these infants are subsequently cared for. So we found that this is one of the areas where there continues to be a lot of deliberation and study about the most optimal protocols for identifying and treating NAS. And there was a question submitted before the webinar that asked about what the next steps might be after the state confirms an increase in NAS births. And while this isn't the only or necessarily the most immediate next step, find out if your hospital has a written policy for diagnosing and managing NAS births. The AAP recommends having a protocol that defines when and how you screen for maternal substance abuse, as well as a standardized plan for evaluating infants that are showing signs of withdrawal. But this doesn't always happen. So the same types of substance exposure protocols, that they might also include guidance on when it's appropriate to report to external agencies. So in this way, correctly diagnosing NAS becomes really, really vital because it has implications for the family beyond just the medical arena because of child protection laws that require reporting. Right now, 18 states consider substance abuse during pregnancy to be child abuse under civil child welfare statutes, but as I mentioned on the previous slide, a punitive atmosphere can sometimes discourage women with substance use disorders from A, getting prenatal care, and from B, seeking treatment because they're afraid of losing custody of their kids. So when you're considering these issues in a public health framework, I would encourage you to do so as opposed to a more criminal framework to increase those opportunities to involve mothers and really engage them in screening, counseling, and addiction treatment. So finally, while we need a lot more research on the long-term health outcomes associated with NAS, in the short term, we need to strengthen collaboration between clinical providers, community agencies, home visiting programs, and state agencies to track drug-exposed women and their infants at least through the first year of life. So the last point that I'll make on this slide is that a lot of new moms go through significant stress in the postpartum period, so it's really important that a discharge plan addresses the mother's substance abuse treatment and identifies those vulnerabilities and ongoing needs for the infant and for the family as a whole. The risk of relapse can be high, and it's important to stabilize the mother to ensure the safety of the infant. So in this way, perinatal home visiting programs can be really essential to promoting better outcomes. So I have just a couple of minutes left, and it was my intent to wind down with a few state examples, but seeing that I'm running a little short on time, I'll just say that these projects are highlighted in greater detail in the ASTO report. They're presented as very short case studies that capture and help to better contextualize some of the key points around data and surveillance, around access to treatment, medication-assisted treatment, and recognizing the need for better protocols for NAS diagnosis and management. So I'm also happy to elaborate on any of these examples during the Q&A. And then finally, I wanted to acknowledge and provide references to a few of the initiatives that are taking place in regions across the country. Many of these groups, these coalitions, these councils have websites where you can find more information about the types of work, the types of projects and works that they're engaged in, and as well as contact information. And a lot of what's happening right now is just testing and applying different QI principles and sharing this data within the state and among professional collaboratives to help move systems along in their efforts. So I will conclude with that. My contact information is on this slide if you'd like to get in touch. And I thank you for your time and look forward to the Q&A.
Great. Thanks very much, Leslie. Clearly, a lot of states have worked very hard on these issues related to opioid use, including newborn issues, and states are important partners and leaders in this area. Third on our speaker list is Scott Pierce, who is currently the Senior Vice President of Blue Care, Enterprise Operations at Blue Cross Blue Shield of Tennessee. And he'll be discussing Blue Cross Blue Shield of Tennessee's creation of an innovative program that's been designed to prevent NAS, known as the Mothers and Infants Sober Together program, or MIST for short. He'll also share how working collaboratively with the state and local communities is helping to make this program a success. Scott.
Thank you. My name is Scott Pierce, and I work for Blue Cross Blue Shield of Tennessee. And we serve about 500,000 Medicaid and CHIP members across the state of Tennessee. And I want to talk to you briefly about this terrible social problem that we're dealing with in the state of Tennessee, and really our health plan's response to that problem. We asked ourselves a lot of hard questions when we really began to study this issue of NAS. And really, I think it really became a question of identity for us. We had to ask ourselves, really, what can a health plan do to solve these very complex social issues? And I don't want to dwell on the problem as much as I do sort of some of the approaches we're hopefully bringing to the table to help Tennesseans. But I would say, I would also give kudos to our Tennessee Department of Health. Our two previous presenters have mentioned them, but our Department of Health has put together a very good surveillance report that really highlights the NAS problem in the state of Tennessee. Unfortunately, I think that report has really led us to an unfortunate milestone. In 2013, we had over 850 babies with a primary diagnosis of NAS. And I would say that that number is low because I know that there's one fairly major county in this state that is underreporting. So I think just to give a lot of compliments to our health department, it really does highlight the problem that we're facing. And we as a health plan began to see the numbers in 2011. We started looking at our own data and saw a dramatic increase in our NICU costs. And just to give you some scope, we spend about $4,000 for the bundle of services that would be included in a normal delivery. If you have NAS as a primary or secondary diagnosis, the average is $67,000. And I would also say that that's probably a low number because there, at least from my perspective, there's little understanding of the long-term cost associated with NAS. So the number that I'm reporting is simply the cost of the delivery and the subsequent NICU stay. But I think we as a society in general just know very little about the healthcare spending of these children as they grow older. It was fairly quick for us to discover the epicenter of this epidemic in our state. And we looked at our own data and found that East Tennessee Children's Hospital in Knoxville had seen a dramatic rise in their census in the NICU. And so we traveled to Knoxville, a group of us in leadership of Blue Care. We paid a visit and we visited the NICU. And what we found at that NICU were rooms of infants suffering from NAS. They were being cared for in dark rooms with volunteer cuddlers, that's what they're called. And these are just citizens who had volunteered to help calm these babies. These babies cry constantly, they shake, and they require almost constant contact with people. So the hospital has created a great volunteer program where people can sign up to come and take a shift and basically rock these babies in these very quiet, dark rooms to try to calm them as best they can. If you're ever in Knoxville, I would encourage you to sign up for a shift. It will definitely change your perspective on this. If you talk to the people that work in that NICU, they will tell you that the problem is not meth, but it's prescription painkillers. And if you talk to those mothers, most of them will tell you that their doctors told them that there was no way that their prescription drugs would affect their baby, which is incredibly wrong. And I know we have policymakers on the phone. We've got to, as a nation, get the word out that we've got to get a better message out to people who are in childbearing years and who are prescribed prescription painkillers. And we also really have to make sure that doctors understand that there should be consequences for prescribing these drugs in massive quantities. We also talked to the Department of Children's Services in Knox County. What happens to most of these babies as they are discharged from the NICU, they go almost immediately into state custody. And the census of children who are in state custody in Knoxville has risen dramatically over the last few years, almost extensively due to this issue. So let's talk a little bit about the opioid prescription rate in the state of Tennessee. And just to show you, this slide shows our state from 2007 until 2011, prescription rate per 100 of the population. As you can see, each year the red is bad, and that means that there are large quantities of prescription drugs being, opioid prescriptions being prescribed. As you can see, with each passing year, the state turns more and more red. I can't help but believe this is also going to tie into Dr. Patrick's chart that showed the dramatic increase of NAS babies. And just to go a little deeper on where the real epicenter of this problem is, the red again is bad. It shows the NAS babies per 1,000. And this is just our own health plan's data, but you see that it really is focused in that Appalachian region of East Tennessee. I visited large NICUs in Memphis, which is on the far west side of the state. They do not have this same problem, so it is very geographically focused for us in that Appalachian region. And just to go to slide 5, this shows East Tennessee Children's Hospital's census. And you can see over the years from 2010 up until the beginning part of 2013, just this dramatic increase of NAS babies at that particular hospital. So I think we saw the dramatic impacts of NAS at East Tennessee Children's Hospital, but the reality is that Children's Hospital does not deliver any babies at all. I think their CEO told me that the last delivery they had in that hospital was, years and years ago. So they basically are just taking transfers from outlying regional hospitals and their NICUs. So we had to do a little bit more research. Let's go to the next level of this and find out where are these NAS babies being born. And that led us to a community in Campbell County, Tennessee. It's a town called Jellicoe. And I'll give you just some of the demographics of that county. It's a population of about 40,000 in that county. It's right on the Tennessee-Kentucky border, and it's essentially an old coal mining town that the coal mining dried up years ago. And it's a very beautiful place, but there are not many economic opportunities in that community. And we found very few healthcare providers in that community, but the ones that we found are absolutely tremendous. And we really refer to them as heroes because they're out in those communities every day dealing with these problems. There's one FQHC, and then there's one very small hospital. And Dr. Thomas, who may be on the webinar, we owe a lot to him because he greeted us with open arms when we showed up in this town. Our data led us to this town, and we basically showed up unannounced at their doorstep, and we had one simple message: what can we do to help? And I think there was initial skepticism of what's an insurance plan doing here unannounced? This has got to be bad. But after they warmed up to us, we have formed very meaningful partnerships. And one of the things that Dr. Thomas told us is that he's basically the only prenatal care provider in that community. He sees basically every pregnant woman in that town. He also tests his expectant mothers for various drug use, and his research is very telling. And I'm going to jump to one slide here real quickly that basically reveals that almost 50% of his females who were in childbearing years, when we define that as ages 15 to 44, were actually using opioid prescriptions. So 50%. It's pretty staggering. So we wanted to do something about this problem, but we really had to ask ourselves, what can a health plan do? And there were a couple of strategies that emerged from that. The first thing that really became our obligation as a health plan is that we have connections all over the state as the largest insurance carrier in the state. We know every provider. We know the state government really well. How can we help build a coalition around this problem? And we began to look at the services that were available in these various communities. And we really came to the conclusion that one of the best things that we could do as a health plan was to try to encourage and persuade and do whatever we had to do to make sure that we could bring the needed substance abuse services to the communities who are in these rural areas like Jellicoe, Tennessee, and bring those services to places where they just historically had not existed. And so if you lived in Memphis or Nashville or Knoxville, you stood a pretty good chance of finding a substance abuse provider that could help you with your problem. But if you lived in a remote area of Appalachian area of Tennessee, you didn't. It just didn't exist. So we've started two programs. I want to talk about both of those. One at the Children's Hospital and one in Jellicoe. Both of those are really aimed at pulling providers of services, substance abuse services, to these communities. And we realize that they aren't necessarily going to prevent the NAS baby that we're dealing with at that point, but we hope to get the mother involved in treatment and hopefully prevent NAS baby number 2 and number 3. So I'm going to go over the details of those programs just very briefly, and I'm sorry I've skipped around the slides quite a bit. The first one is a program we started at the Children's Hospital, and we call it New Beginnings. And New Beginnings is an idea that mothers of these NAS babies are transferred to East Tennessee Children's Hospital, and what happens is they are usually confronted by a Department of Children's Services caseworker who is unfortunately has to deal with potentially placing that child in state custody. So we've worked with the Children's Hospital, with DCS, and with a local mental health, behavioral health professional facility in Knoxville called Helen Ross McNabb, which is a wonderful facility in Knoxville. And what we try to do is make contact with those mothers while their baby is in the NICU, and we have a very frank conversation with them about the reality of what might happen and what usually happens in these situations. We don't want to see the child go into state custody, and neither does the mother. And so we present a treatment path at that point in time and say, if we want to prevent this bad situation where the state might have to come in and become the legal guardian of your child, let's talk about what kind of treatment we can provide. And there are a lot of strategies that go with that conversation. And basically what we've done is we've talked to these mothers what would be useful to them in that situation. So we will feed them, for example. We will have meetings, and we will provide food. And, you know, if any of you have been with a family member in the hospital, a good meal is very welcome. So we've tried all of these strategies. We offer them, they're called baby bucks, but they're essentially gift cards where they can use to buy things that they might need for the child once they get home. So we use all of these strategies to engage them in this conversation. The conversations might be heavy-handed about talking to them about what might happen in this situation with DCS, to warmer conversations about, hey, how can we help you with buying formula, etc. Children's Hospital has been great. They've given us some space to do this. And so basically what we did was we were a consensus builder. We pulled people around the table. We're also a funder. We are paying for the startup of these programs, and we have a lot of high hopes for new beginnings, and that is at the Children's Hospital. I want to talk to you about another program that we call MIST, and that is a program that we started in Jellicoe, Tennessee. And one thing I would say about that is most of the times when a health plan starts a new project, they traditionally go towards the big cities. That's where most of the providers are. That's where most of your members are. It's actually been very rewarding to start a program in a town that has not traditionally gotten a lot of attention. And so we had a kickoff for the MIST program last summer, and we had fantastic participation by our state government, our Department of Health, our Medicaid agency. We had providers, Blue Cross was there, and basically what we did was put a stake in the ground in this small town on the border of Tennessee, Kentucky, that said we've got to really intervene here. And so what the MIST program consists of a case manager, a counselor, and a program manager who work together to support and care for the families who are struggling with substance abuse. The program is fully integrated into the operations of the FQHC in that community. And we, again, found a willing provider who was from the Oak Ridge area who was willing to come up to Jellicoe and offer services where they had just traditionally not served those communities. But the team connects with moms through a variety of channels. They perform home visits. They do individual therapy sessions. They do weekly support groups. Moms are welcome to bring their children with them. But again, the whole idea, sadly, we may not prevent NAS or NAS baby number 1, but we're really trying to intervene to prevent NAS baby number 2 or 3. And again, I started, what can a health plan do? I think the best things health plans can do is bring people to the table, convince providers to serve underserved areas, be partners with the providers who are already in underserved areas, make sure that you are not only a champion but also a funder. So we have committed about $290,000 to support the MIST program, and I would say that it's a huge uphill fight to try to solve the prescription drug abuse problem in this state. But we have lots and lots of people who are very interested and dedicated to this. But it has been tremendously rewarding on a personal and professional level to meet the people who are out there combating this every day. And again, if you ever get a chance to hear Dr. Thomas speak about this issue, you will be better off for that. So that's essentially what we're trying to do to combat this problem.
All right. Well, Scott, thanks so much for your insights and your really good work in this area. It's great to hear how some of these more vulnerable women and children in Tennessee will be able to benefit from the programs you presented today. So finally, I guess I get to wrap up. First of all, I'd like to say that I'm a practicing neonatologist in Northeast Florida, which is one of those hot states for this issue. And so I'm on the receiving end of having to treat these babies and their families when they come into the NICU with signs of NAS. I've worked with our State Department of Health, which has been very, very proactive in association with Pam Bondi and other people in the state government to make an impact in Florida. One of the endeavors that we have accomplished is making NAS a reportable condition, slightly in a different way than Tennessee has, but in a way that we think will be useful. And I've also been the lead author of the updated clinical guideline on NAS by the American Academy of Pediatrics, which is in the resource list. So what can I tell you about my county, Duval County, which is really the city of Jacksonville? We are certainly very much impacted by NAS. In 2012, we had the unfortunate distinction of surpassing Orange County and Tampa and Miami, in terms of number of cases, we had 215 babies just in Duval County with NAS that were cared for in 2012. So that is, pretty huge, and has certainly been a major impact here, as Scott said, in terms of increasing the number of days in the NICU in the census. So by way of disclosure, I don't have any conflicts of interest, financial or otherwise, germane to this presentation. I will note that our center will be participating in a multi-center NIH-funded study that seeks to see whether methadone or oral morphine is more effective in treating NAS, and that by itself probably tells you something about the state of the clinical art. So what is the potential inventory of effects of antenatal exposure to opioids on the developing fetus and growing child? And this is a subject of which one could have a couple lectures, but I'll just touch on a few things briefly. First of all, there is a slight increase in certain types of congenital abnormalities, including certain types of congenital heart disease, hypoplastic left heart, AV canals, conotruncal defects, neural tube defects, which are things like meningomyelocele, and also abdominal wall defects like gastroschisis, but these are increased by odds ratios of anywhere from 1.8 to 2.7, and these each by themselves is very small, so one does not notice any epidemic of these problems among babies with opioid exposure. There certainly is an effect of opioids on decreasing fetal growth, and there's differential effect depending upon the opioid that the mother is exposing the fetus to. We all know that there is a profound constellation of neurobehavioral abnormalities that can occur at birth, which is the syndrome of neonatal abstinence. Many people are interested in the long-term effects of opioids on the fetus and then into the growing child, and again, this is very complicated. The data are relatively meager and confounded by many other variables, but I think it's safe to say that there is likely a small but variable increase in things like behavioral problems as children grow up, attention deficit disorders, which present in the school-age years, and issues with memory and perception. The effects of fetal exposure to opioids on intelligence quotients and executive functioning, which is a higher level cognitive functioning that makes sure that people make smart decisions, they're really unknown. It hasn't been studied. But what I can tell you is that the outlook is not always poor. In fact, that there are many of these babies that if they are brought up in a nurturing environment, turn out to be perfectly normal. So I think that's the good news there. The topics of interest here on prevention, I think that Cece and Leslie and Scott have touched on many of these issues. I'll just echo them, that I do believe that education of providers and the public is really key. It is just unbelievable how ignorant people are about the effects of these drugs, even in relatively short courses of treatment. I think providers can be educated on different classes of drugs with which to treat pain. Certainly as a medical profession, the pendulum has swung very much over the past 10, 20 years toward really meticulous attention to pain in patients, and probably swung past the appropriate balance point. And the public obviously is not very aware of these things either. So I think that will really be key, and that's obviously when I think will be the biggest payoff eventually in terms of preventing opioid dependency in the general population. And that really is a huge problem. I don't know if you know this, but recently the number of deaths in this country due to drug overdoses, including mostly prescription drugs now, has exceeded the number of deaths due to motor vehicle accidents, and that's really a scary statistic. Another way for primary prevention is to concentrate on effective contraception in at-risk mothers, and many of these mothers are younger women in their late teenage and early 20s. There is, I think, inconsistency among health plans as to whether or not they'll cover the most effective contraception, such as the implantable contraceptive rods, which have a 0.2% failure rate compared to 9% in practice with the routine oral contraceptive medications. So that's certainly something that can certainly prevent exposure of a baby. I I think the role for inpatient medically supervised maternal detoxification can be revisited. There is experience in centers that have done this, that this can be done safely. A lot of the concern by the American College of Obstetrics and Gynecology has been related to data looking at really adverse consequences on the fetus, including death, if a mother, quote, cold turkeys, unquote, from heroin or medications, other opioids. Whereas in an inpatient medically supervised detox, with the carefully selected population of mothers who show the appropriate motivation and have the appropriate psychosocial profile, I think that might be something that can be looked at least in a research fashion. There are clearly differential effects on drugs on the likelihood, timing, and severity of NAS, and I think I've got a slide coming up that looks at that. So heroin is the illicit drug that has a very short half-life. Babies born to mothers on heroin generally, if they're going to exhibit signs, do so before 24 hours of life. The severity of signs is mild to moderate, and the likelihood of having signs is relatively low for this class of agent. Methadone and buprenorphine have longer half-lives, so they tend to present later. Methadone usually presents between 24 to 48 hours of age, but may not present until 3 to 7 days of age, depending upon metabolism. Buprenorphine also is between 1 to 3 days. And the symptoms with methadone tend to be moderate to severe and occur at very high likelihood, up to 94% in some series, but not invariably. Buprenorphine tends to have more mild to moderate symptoms, and the risk of a baby having this problem is lower. And I want to present a little data from Dr. Andre Jones' study that was published in the New England Journal of Medicine in 2010, where she looked at women who were randomized to maintenance with methadone versus buprenorphine. And you can see in this graph that the length of infant hospital stay, the duration of their withdrawal signs and their treatment, and the total dose of morphine in buprenorphine was significantly less than those babies who had been born to mothers who had been maintained on methadone. So there might be an opportunity here from a public health, public policy point of view in terms of treating these mothers with the goal of minimizing the signs of NAS in babies. The buprenorphine also causes a different type of constellation of signs, whereas methadone babies tend to have a very high component of tremor, hyperactive moros, and motor signs. Babies with buprenorphine, exposed to buprenorphine, tend to have a higher rate of nasal stuffiness, sneezing, and loose stools. Now, the presentation of NAS, like I said, is variable. There are lots of factors that enter into that, some of which are understood, some of which are beginning to be elucidated. I mentioned the drug and the amount and the frequency. There are cofactors involved. So I think Leslie talked about the influence of tobacco, which certainly exacerbates the signs of NAS in babies. Also, benzodiazepines, alcohol, cocaine, marijuana can also exacerbate signs, as well as stress and other comorbidities that the mother is experiencing. There are certainly placental factors, there are infant factors, and genetic and epigenetic factors that are beginning to be understood. In terms of other prevention things, secondary prevention refers to the prenatal identification of at-risk infants and their monitoring, and I think that what we're seeing now is some areas of the country exploring with universal testing, not screening, which is a verbal sort of interaction, but testing, which is a biological testing of women in labor, sending urine tests and so forth to look for possible opioid exposure. And so there'll be a lot coming out on that in the next couple years as to whether or not that has utility in identifying babies before they go home. Clearly, babies need to be monitored for the appropriate amount of time, and that will depend greatly upon what kind of drugs the mother was taking. If you have an accurate history and some maternal drug testing that will help identify that. In terms of treatment, lots of issues here. I'll just sort of touch on a few. Clearly, the quantification of the severity of NAS is important. That is usually done by something called the Finnegan scoring tool. And this shows you all the different categories. The point here is that it's very important for the staff who is administering this tool to be well trained, to minimize any inter-observer variability, and to truly make this a useful tool. The goals of treatment have to be kept in mind, and the goals of treatment really are to minimize and not eliminate the signs of NAS. If one eliminates the signs of NAS, the baby will be so treated, the baby will be in hospital for a much longer period of time. It's important that we ensure normal growth patterns or the rate of weight gain in these babies, help them establish normal sleep-wake cycles. We want to promote their interaction with their parents, caretakers, and so forth, and we want to avoid complications such as fever, seizures, or skin breakdown. There are a variety of non-pharmacological treatments that are effective, and I think that Scott referred to some, including the dark rooms and the voluntary treat the families concurrently, recognizing that in most communities, these babies will go home with the family. So you need to work with them to show them empathy, be non-judgmental, and help them with their parenting skills so that they avoid child abuse in the future. And you promote a long-term supportive environment at home. Also help the family identify resources, and I think a few of the speakers talked about that. Pharmacological treatment, the goals are to allow the infant to tolerate mild signs of withdrawal. There are a number of medications that have been used to treat, and I've listed those in the slide. The practice currently in this country is the first-line treatment is usually, but not always, an opioid, mostly oral morphine, sometimes methadone, but there seems to be a significant and growing use of phenobarbital as a first-line treatment. The initial dose in most units is titrated to the Finnegan scores. And if signs of NAS are not relieved by the maximum dose that's felt to be safe for a single drug, a second or adjunct drug is added, and typically that's phenobarbital, less commonly clonidine, and sometimes a benzodiazepine. Typically a dose is weaned by 10 to 20% every 1 to 2 days as long as the Finnegan scores are less than 8. Now the current state of the evidence with respect to treatment, this is one of those knowledge gaps that was discussed. We do not know from the existing published data what the most effective drug class is. We suspect it's opioids. Or the most effective agent within a drug class is. Endpoints vary. Treatment failure means the baby requires a second drug for treatment, so that's important to avoid. Length of stay in the hospital is an important endpoint. Total dose of the drug is maybe a less important endpoint. But all of the studies that have been published, or most of the studies, really have methodological weaknesses that limit their utility. Important to note that protocols that use the Finnegan scores to initiate therapy are based on a precedent but not on evidence. So, for instance, we have no reason to think that starting babies when they get to a score of 8 is a better practice than starting babies when they get to a score of 10 or 11. We do know that having a protocol and adhering to it reduces the length of hospital stay, and there will be data coming out of the Ohio Collaborative that shows that very persuasively. One clinical study looking at adjunctive treatment, this is the second drug therapy with clonidine versus phenobarbital, shows you some of the philosophical issues that arise in interpreting studies. So this is a study where babies were randomized when they needed a second medication to either clonidine or morphine. Relatively few babies were studied. The primary outcome was the days of morphine therapy. And the table shows that clearly if you treated with phenobarbital as opposed to clonidine, you had fewer days of morphine and a lower morphine dose. However, the flip side of that is that the babies who are on clonidine had the clonidine weaned off in hospital. Babies on phenobarb could be discharged on phenobarbital, and in those cases, the home duration of treatment of phenobarbital was 3.8 months up to 8 months, and one can debate whether or not that's a good thing. And then one technical point, and I'll end with this, is treatment protocols, drug regimens are very important. I think a lot of clinicians do not really understand necessarily the pharmacokinetics of the drugs. If one starts with an excessively high morphine dose, for instance, if you would start with, to be technical here, 0.5 milligrams per kilogram per day, opposed to 0.25 milligrams per kilogram per day, you've probably committed that baby to 10 unnecessary days in the hospital if the baby were able to tolerate being treated with the intermediate dose. And also, half-life makes a difference. So in 12 hours with a low half-life drug such as morphine, you reach a steady-state concentration, so the baby is, well treated. And if you keep dosing every 3 hours, the baby has a nice steady-state level. If you use methadone, however, this slide shows you here in the middle sort of seesaw bracket, it takes time for methadone with a longer half-life to reach an effective level, which is indicated by the blue horizontal line. Whereas if you give a loading dose and then give a maintenance dose, you're pretty much at that therapeutic level at all times. So you may be able at 12 hours in the baby who's traditionally dosed not to have sufficient relief and be motivated to increase the drug dose, whereas that is really the inappropriate approach in this case. So those are just a few things. And just to sum up real quickly, because we want to leave a few minutes for questions here, you've heard a lot of information today about the many ways that NAS impacts our communities and our country. But you've also heard some unique and innovative ways that public and private sectors have come together to try to reduce, the number of these babies who experience these awful signs. So we'll open it up for questions. I'll ask our operator to explain. How you can ask a question if you're on the phone. Like I said, you can also submit electronically through the question window at any time. So I'm looking for questions here. This is a new learning experience for me. And I guess what I'll start with is some of the questions that were submitted ahead of time. So one for Cece. There's a great deal of interest in hearing from you, from your point of view. What are the most important things that health plans and states can do to support your work to prevent AS through your office and other things the federal government is doing?
Hi. I think that one of the things that we're very interested in is encouraging prescriber education, encouraging plans to look at sort of how the pharmacy benefit system is run. Is it, necessary to prescribe 30 of something? Could you be prescribing 3? Does the system automatically default to prescribing 30 days versus prescribing, just for what is needed? And, looking at identifying people as early as possible. And also, this is with the Affordable Care Act. I know not all states are engaged in the Medicaid expansion, but having medication-assisted therapy for the women who need it as an option for treatment, and making sure that prescribers are reimbursed for that, I think is really important.
Okay, I'll take a couple questions here that relate to, that have come through on the board. One of them is breastfeeding encouraged with babies who are born to mothers on methadone? And the answer to that is if a mother is in a maintenance methadone program and she has been followed and she has been verified by testing to be free of other harmful exposures, and she doesn't have any of the contraindications in terms of infectious risks, then yes, breastfeeding is very helpful for those babies. There is a minimal amount of methadone that's excreted in breast milk, and it's not something that's going to really have any effect on the baby. So both the AAP and the breastfeeding organization within the AAP do support the utility of breastfeeding. So I think two people asked that question, actually. Question on follow-up: is anybody sending babies home on morphine or methadone? Now, this is another fascinating question here. I had it listed on one slide, but didn't get a chance to discuss it. There are communities where, by necessity, they've had to work out a outpatient plan of management. I have spoken to several physicians in an area of West Virginia that, like Appalachia and Tennessee, is overrun by this problem. They have told me that if they were to send every of these babies off to the level 2 NICU that's 50 miles away, that NICU would be overrun. So the community has come together and figured out how to make sure that these babies, through the 2 pharmacies in the community, get their daily dose in syringes, just 1 day's dose in syringes that's accurately dispensed, and then they have follow-up with the pediatricians. So the 5 or 6 pediatricians in the community and the 2 pharmacies have worked this out, and it apparently is safe. They do some screening of the mothers to make sure that they're well qualified to do this. There have been episodic reports of home programs where babies have been misdosed and have come into emergency rooms with apneic arrest. So I think it's something that one entertains very carefully. There is some data in the literature about it. And then Leslie, what advice do you have for health plans looking to partner with state health departments in this area?
Great. Thanks for the question. So I think step 1 is to know who your health commissioner is. And I think it sounds like a really simple and basic suggestion, and it is, but I think it's important to know the leadership team that's responsible for overseeing a lot of the activities and functions at the health department. So I would say find out what, if anything, the health department is doing around NAS or around substance abuse prevention in general. The odds are good that there's something happening. And health departments are often responsible for a range of health promotion activities, including things around substance abuse. And health plans have the potential to reach lots and lots of people. So I would encourage you to think about what kinds of information could also be disseminated to your members or to the providers in your network to really increase that patient-provider outlet of communication. So maybe it's a joint statement or a Dear Colleague letter or something like that to really generate awareness about whatever aspect or aspects of the issue, depending on the audience you're trying to get at. And the financial implications, I think, associated with NAS have been pretty well established. And so see if the state has captured any of that cost data to really make the business case for why it's important to address for both the business side of healthcare and then more globally for health systems. And in terms of direct services where there might be some areas of strong mutual interest and where health plans may want to think about partnering with the health department, both tobacco cessation programs, as I mentioned earlier, and home visiting programs come to mind. About 45% of state health agencies directly perform home visits, so I think there's a potential opportunity to link with community health workers, or there's opportunities for health plans to strengthen the workforce development needs as far as community health workers go to help connect members with the health system to help them kind of navigate through and put them through to more community-oriented services. And I think that there are lots of other points of confluence, like with these QI councils, where health plans have the opportunity to come to the table as well.
Okay. Well, listen, I think we have time for one more question, so I'll ask our good operator to see if he has any questions that have come in that are burning that perhaps Scott can address.
Ladies and gentlemen, if you have any questions at this time, you may press the star followed by the 1 on your touchtone phone. If you're using a speakerphone today, please lift the handset before pressing the keys. Once again, ladies and gentlemen, if you have any questions, please press star 1 at this time. And we do have one question in queue from Sandy Jones. Please go ahead.
Hi, I was wondering if there's, he mentioned the different responses you would see in a baby withdrawing from Suboxone versus methadone, and I'm wondering if there's anything related to SSRIs, what type of withdrawal symptoms we would see in those children who seem to not do so well about 2 days after birth as well.
So I will refer you to the AAP statement on neonatal drug withdrawal, which covers that pretty completely, but SSRIs are a slightly different situation. They don't really cause withdrawal in most cases. Long drug effect that becomes evident, by 1 to 2 days of age, but it's not something that requires or has required pharmacological treatment. So I'll refer you to that, and I think that'll provide you some helpful information if that's okay.
Yep.
So it is almost 3 o'clock. So I think we're out of time for our question and answer session today. I'd like again to thank all of the excellent speakers who took time out from busy schedules, I'm sure, to share their insights and experiences in this important issue. I've been asked to ask you all that if you haven't yet filled out your survey, take a moment to do so, and you can access that by clicking on the arrow on the slide screen right now. So thank everybody on the call for joining us. And thank you again to NIHCM and to ASTO for organizing this webinar on this topic. We certainly hope it has provided you with information and insights that will be helpful and productive to you. So everybody have a great day.
Ladies and gentlemen, that does conclude our conference call for today. We thank you for your participation. Now disconnect your lines and have a great day.